Inner ear or labyrinthine development start during third week from the thickening of the surface ectoderm on the either side of the rhombencephalon, resulting in otic placoid formation. At third week, there is otic placoid from the thickening of the ectoderm at the level of rhombencephalon. If this fail to develop, that can lead to complete labyrinthine aplasia or rudimentary otocyst. At fourth week, this otic placoid invaginate and form the otic pit, and this otic pit ultimately falls off and form the developmental otocyst. At fourth week arrest or developmental failure can lead to cochlear aplasia, common cavity, enlarged vestibular aqueduct or cochlear aperture anomalies. So at fourth week, these four things can be developed. If this further development of the labyrinthine arrest at fifth week or sixth week can lead to cochlear hypoplasia. And further, at seventh or eighth week, this arrest can lead to incomplete partition in the labyrinthine or cochlea. So this cochlear development is start from the third week and it almost complete around eighth week. Between third week and eighth week, if this development arrest, there are different eight type of anomalies can develop. That eight type of anomaly is best described by the Sennaroğlu 2017 eight domains worldwide classification. The development of cochlea is completed in the eighth week. The vestibule completed about 11th week and semicircular canals between 19 to 22nd week. Superior is first to develop around 20th week, followed by posterior around 21st week, and last semicircular canal is developed horizontal around 22nd week. The inner ear made up of membranous labyrinthine that is inside the osseous labyrinthine. The cochlea organ responsible for hearing is a conical structure consisting of a duct that make up around 2.5 to 2.75 tons around a central core called modiolus. From modiolus, a thin osseous spiral lamina or layer reaches out to divide the duct into the scala vestibuli above, in between scala media and below the scala tympani. Through cochlear opening, cochlear aperture or lamina cabrosa, the cochlea meets to the fundus of the internal auditory canal and from which the cochlear nerve passes through and reach to the cochlea. There are four genes which are responsible for cochleovestibular malformations are DIX, DIX, SOX, SOX, FGF and FOX, FOX. These are the four genes which lead to this congenital labyrinthine anomalies or cochleovestibular malformation. Now, first from the Sennaroğlu classification 2017 is the complete labyrinthine aplasia or Michel deformity that around third week arrest. There is total absence of inner ear structure. Internal auditory canal is atretic or absent. Facial nerve trajectory is aberrant. Petrous apex hypoplasia is there and there is absence of round window, oval window and there is flattening of the middle ear and there is medial wall is completely flattened and there is on medial wall there is absence of promontory. This is absolutely contraindication of the CI. There is three type with hypoplastic or aplastic petrous bone, without otic capsule or with otic capsule. So these are the three class. With hypoplastic petrous bone is first, second is without otic capsule Third one is with otic capsule. There is associated mutation of OXA is there, that is vascular anomaly, facial weakness, hypoventilation syndrome, that is OXA mutation is can be associated with this. And another is the LAM syndrome, LAMM syndrome. This is FGF3 mutation that lead to macrocia or macrodontia. Second class is rudimentary otocyst. This is Michel otocyst deformity. Around third to fourth week arrest, this rudimentary otocyst is very small cystic structure without formation of internal auditory canal. It is also a contraindication of cochlear implant. Third is the cochlear aplasia that develop because of fourth week arrest. Features are: first is there is complete absence of the cochlea. Second is the labyrinthine segment of facial nerve displaced entirely. Third one is vestibules and semicircular canals occupy their normal anatomical location in the posterolateral part of the fundus of the internal auditory canal. And there is cochlear nerve is also absent. So it can be two types. First is cochlear aplasia with normal labyrinthine. Second is cochlear aplasia with dilated vestibule and semicircular canals. So this cochlear aplasia is also a contraindication of cochlear implant. Fourth entity is common cavity. It is first described by Edward Koch in 1838. It is because of arrest at fourth or fifth week of gestation. Features are: number one, it defines a single large ovate or round structure representing cochlea and vestibule. Contains neural element of both cochlea and vestibule. Third one is rudimentary parts of the semicircular canal can be present. Fourth is the internal auditory canal is well developed and enter the mid portion of this cavity. You can see this mid portion and it's going into the common cavity. Fifth is common cochleovestibular nerve is present which going in common cavity. Occasionally separate cochlear or vestibular nerve can be seen. Sixth feature of this common cavity is cochlear implant is an effective treatment for common cavity. Surgical approach for CI is by transmusted banana-shaped labyrinthectomy, which was first described by McElveen et al. Eighth is as neural element in this common cavity, mainly located at the periphery of the cavity. That's why straight electrodes are preferred, while pre-curved or half-bended electrode should be avoided. The length of the electrode array can be calculated by using the formula 2 pi r, where r is the radius of the common cavity. So applying this on CT 1 by 1 ratio, you will get the length of the electrode. So by center of this common cavity, you can calculate the length by applying the radius in the 2 pi r formula. To differentiate this common cavity from cochlear aplasia with dilated vestibule, there is most of the part in cochlear aplasia is situated behind the line of this internal auditory canal, while in common cavity this line is in the center with the common cavity. So this is the difference between the common cavity and cochlear aplasia with dilated vestibule. Fifth entity is the cochlear hypoplasias. It is smaller external diameter cochlea with cochlear duct length is less than 25 mm. It may present with various ways like profound loss, normal, conductive or mixed hearing loss. Patient with pure conductive hearing loss can be addressed with STP surgery. Cochlear nerve deficiency is frequent in cochlear hypoplasia type 4 and facial nerve may have anomalous course. Better to use smaller and slimmer electrode in this cochlear hypoplasia cases. This cochlear hypoplasia is four type: CH1, CH2, CH3 and CH4. CH1 is smaller bird-like cochlea. There is no interscalar septa or no modulus. In type 2, it is cystic hypoplastic cochlea, absent modulus, and interscalar septum is also absent. Vestibule and vestibular aqueduct may be enlarged. There might be defect between the internal auditory canal or cochlea. Higher chance of gusher during surgery is there. Stapedial foot plate defect may be present. That may present with meningitis or CSF otorrhea. Full banded lateral wall electrode are used in cochlear hypoplasia type 2 because it is cystic hypoplastic cochlea, small cochlea is there. In cochlear hypoplasia type 3, there is shorter and fewer turn of the cochlear duct, less than 2.5 turns. There is shorter interscalar septum and modulus are also very short. In type 4, cochlear hypoplasia, there is normal basal turn is there, but hypoplastic middle and apical turn is there. With cochlear hypoplasia having facial nerve anomalous course. So these cochlear hypoplasias can be addressed by different method according to the hearing loss. It by stapes surgery or with the cochlear implant. So by imaging you should decide which implant and which type of the cochlear hypoplasia is there. Sixth entity is incomplete partitions. It is a group of anomalies where the differentiation between the cochlea and vestibule is clear cut. The differentiating feature from cochlear hypoplasias is that in IP the cochlea is of normal length and that is more than 25 mm. There is three type of this incomplete partition are there according to interscalar septa or modulus. In IP1, there is cystic cochleovestibular malformation is there. There is normal external architecture of the cochlea. There is absent both modulus absent and absent interscalar septa is absent. There is dilated vestibule is there and defect between the cochlea and internal auditory canal may be there. There is no modulus. The nerve ending along the periphery. So best electrode in this case is full bended lateral wall electrode can be used. There is big cochleostomy, let CSF flow and then you can insert the implant. In IP2, there is apical part of modulus and corresponding interscalar septum are defective. There is cystic apical part due to fusion of the middle and apical turns is there. This deformity, if added with enlarged vestibular aqueduct and dilated vestibule, this deformity is called Mondini's deformity. Hearing loss may be normal to profound is there. There is no CSF gusher is there. Any kind of electrode can be used in this type of the IP2. It may associated with Pendred syndrome and DiGeorge syndrome or Mondini's deformity. So this IP2 can be associated with Pendred, DiGeorge or Mondini's deformity. So in this case, you can use any kind of electrode. In IP3, absent modulus is there with interscalar septum is present. It is mostly X-linked deafness with defect between the internal auditory canal and cochlea is there. There is 100% chances of gusher is there. And here full banded lateral wall electrode is used as cochlear implant. Facial nerve anomaly may be present with this IP3. So incomplete partition. Type 1 there is both interscalar septum or modulus is absent. While in type 2 there is absent interscalar septum or defective interscalar septum is there while modulus is present. In type 3 there is interscalar septum is present while modiolus is absent. Seventh entity is enlarged vestibular aqueduct. It is one of the most common inner ear malformations. Vestibular aqueduct is enlarged, and vestibular aqueduct is a bony structure which contains the endolymphatic duct which connect the inner ear to the endolymphatic sac, which is situated in the posterior cranial fossa. Various criteria for EVA. First is Valvasori and Clemmis criteria, which says if midpoint of this duct is more than 1.5 mm, so this case is a enlarged vestibular aqueduct. This midpoint is between the vestibule and operculum, while Cincinnati criteria says width midpoint if more than 0.9 mm and operculum width more than 1.9 mm. That case having EVA. While Wilson's criteria says any segment of the vestibular aqueduct if size is more than the size of the diameter of the posterior semicircular canal, then this case may have enlarged vestibular aqueduct. So EVA can be sign of genetic disorder, that is also Penrod syndrome. This Penrod syndrome is a progressive sensory hearing loss with goiter with enlarged vestibular aqueduct. Is a genetic disorder. Eighth entity is cochlear aperture anomaly, also known as cochlear fossette anomaly. This cochlear aperture is a bony cochlear nerve canal which is carries the cochlear nerve fiber from the internal auditory canal to the cochlea through the modiolus. If there is atresia or stenosis of cochlear aperture, which can correlate with the cochlear nerve deficiency. Cochlear aperture normally is more than or equal to 1.5 mm at the mid portion of the mid-modular level. If cochlear aperture stenosis is there, then this mid-modular width should be less than 1.5 mm. When cochlear aperture is not visible and it is occluded by the bony tissue, then this cochlear aperture is called atretic cochlear aperture. Approximately 33% of the ears with bony cochlear nerve canal anastomosis or there is canal stenosis there who are having hypoplastic or aplastic cochlear nerve. All patients with bony cochlear nerve canal atresia had cochlear nerve deficiency. The cochlear nerve was hypoplastic or aplastic when the diameter of the internal auditory canal is less than 2 mm. Cochlear aperture can be normal, hypoplastic, aplastic or wide. Cochlear aperture aplasia or hypoplasia are most commonly seen with the charge syndrome or charge association. There are some cochlear nerve anomalies are also there, which in newer classification by Sennaroğlu is divided into 6 types. Type 1 is normal cochlear nerve, type 2 is smaller cochlear nerve, type 3 is no cochlear nerve, and type 4 is normal cochleovestibular nerve for the common cavity. Type 5th is hypoplastic cochleovestibular nerve and 6 is absent cochleovestibular nerve. It is according to the facial nerve diameter. If this cochlear nerve diameter is less than the facial nerve diameter, then it is cochlear nerve anomalies or hypoplasia or absent or hypoplastic cochlear nerve.